Hello and welcome back to the Neurotransmitters. I'm your host, Dr. Michael Kentris, and today I'm happy to revisit a subject very near and dear to my heart and hopefully to yours as well, which is medical education in neurology. And to help me on that journey today, I'm happy to introduce Dr. Brian Hanrahan. Please let everybody know kind of who you are, what you do.
All right, Michael, thank you very much for having me. It's a great honor to be here. So I am the Assistant Program Director of Neurology Residency, as well as a Fellowship Director of Clinical Neurophysiology. I'm board certified in neurology, clinical neurophysiology, and epilepsy. In addition to those clinical and medical educational roles, I'm also co-founder of the medical educational platform, Now You Know Neuro.
Awesome. So as someone who also has engaged in the online space, kind of in the medical education space, kind of independently to an extent, I was really happy to hear from you and to kind of hear about sort of your journey from, and we can go back as far as you want, whether med school, residency, or wherever you think it makes sense to kind of pick up the tail and kind of talk about how you went from kind of trainee to medical educator.
Yeah, I love telling this story. So, to be honest, I was always interested in education. My mom was an elementary school teacher. I grew up in a family of educators in the elementary level. I was the first physician in my family that went to medical school. And during my medical school years, I still really enjoyed, interacting with the clerkship directors and kind of learning how medical education was done. When I got into my neurology residency and I was starting to prepare for the in-service examinations, I just felt there really wasn't very good resources available for us to kind of optimize our knowledge and time to prepare for these things. So after I went to the AAN conference as a PGY2 and kind of just communicating with other leaders in the field, I kind of realized that this might be something I need to kind of tackle myself. So during my first, PGY2 and PGY3 years, I started working on developing some text-based content for preparation for the in-service and board examinations. But I really didn't have an idea of how to kind of share that information in the future. I figured that would be a future problem for me. Fortunately, one of my junior residents, Steve Gangloff, has a lot of experience in coding, and website design. So I met with him kind of the end of my PGY3 year, beginning of PGY4, and kind of, gave him a pitch of like what we think we could put together as an educational resource for residents, and he was totally on board. So now that was about longer ago than I'd like to admit, probably about 7 or 8 years now. We had the website launched probably around 2019. And then at that time, it was primarily text-based chapters and an image database with radiology, EEGs, EMGs, and pathology. But since then, we really have kind of evolved into have many more modes of learning, including flashcards. We now have about a 1,300 multiple choice question bank, and slowly adding more audiovisual content onto the site as well.
Awesome. Yeah. I remember coming across the website. Unfortunately, I had been like you said, also longer than I care to admit, out of residency for a couple of years when I saw it out there. And I do think back kind of to that landscape, right? I took my boards in 2017, and as you said, there were a handful of resources out there. In terms of I was fortunate enough, one of my attendings was Dr. Esteban Cheng, who kind of put together for any of the neurology residents out there, that kind of question comprehensive review in neurology, I think is the title, which very frustrating book, but also very good as far as that textbook is. And then everything else, it always seemed like you were saying, all these different residency programs had their own little pockets of things that have been handed down from generation to resident, but hadn't really been widespread. And it seems like this is kind of that writ large to an extent.
Yeah, I mean, it's something that has been grown and fostered from interacting with residents and leaders in medical education across the country. I think there's probably been 50 to 60 people that have touched it in some way, whether it's writing a question, reviewing a chapter, helping me with the flashcards, giving lectures. So many hands make light work. And it's crazy to think kind of how large and robust it is at this point. And I think, Mike, you hit a great point at that. Smaller programs, newer programs don't have that internal resource available. You can imagine it, when I became an assistant program director at my program, we just started it. So we had to create a 200-hour lecture series in the first year out of scratch. It's incredibly hard when you don't have that, those years of research or old lectures to kind of build on to kind of get to the point where you're on the same tier as well-established programs that have been around for decades, if not even longer. So this kind of helps programs kind of get to that level very quickly. And it's great to see how some training programs have incorporated my content into their curriculum, whether it's question review or in some other modality, because it really, it's very rewarding to me to kind of see the amount of influence I've been able to have in people that I might not even know personally myself, but it seems to have still some value.
No, that's excellent. And one of the things I thought was interesting is that, you do have on the website the option for, say, an institution subscription as well. And I'm just curious from your own perspective, when, let's say a residency program signs up for, a year or a board review series or what have you, do they find that there's an objective increase in either board passing rates or in terms of their in-service exam scores going up, or what kind of metrics do they report back to you, or what kind of feedback do you get from the users of your services?
So subjectively, we get really great feedback. The one thing that we've kind of learned is if we set up an institutional account or even a free trial for an institution, in the time leading into the in-service exam or just at the beginning of the academic year, the retention rate is extremely high. So if people didn't like it or find it rewarding, they wouldn't continue to stay with us. It's a little harder to get that objective data because I think, what metrics would we use necessarily? You could use board pass rates. Utilizing the in-service exam for something like this is something I think the AAM would probably not look kindly upon. They would probably frown upon that because of, it's really a marker of academic performance and gives you insight into how your residents are performing and what, deficits they may have that they can focus their attention on before the following year or before their boards. So it's been hard to kind of find that objective data, although we do have a lot of survey-based insights into the user experience, and it's overall very positive.
Yeah, no, that's a great point. I do remember as an anxious fourth-year resident myself, looking back to see how worried do I need to be about my in-service exam scores versus my likelihood of passing my boards. I think I only found one paper from the early 2000s or 2010s that was looking at there is an association. It was fairly strong, but not super robust. But yeah, it is one of those things that I think you are absolutely right. And, we don't need to lean too much on the in-service exam, right, as far as board passing rates and things like that, because that, as you rightly said, is not the intent of the test.
Exactly.
It's not there to be a punishment or a scourge for those who didn't perform well. Hopefully, more encouragement.
Many PGY2s come in thinking it's something as serious as a shelf exam in medical school or something like that. And we kind of have to reassure them that, no, that's not how this works. This is really just a marker. Only the academic leadership at your institution should know your performance. And if anyone asks in your interview season, you got to let us know because we actually, I think the AM encourages you to report that type of behavior.
Yeah.
Another thing to build on that, Mike, you mentioned that research article. You're right, that was published by the AAN. I don't remember the exact numbers off my head, but I think there was a 99 pass rate if your score was was 65% or higher.
Yeah.
So 65% of the questions correct.
Right.
So that's pretty dated, and the RITE exam has had some dramatic improvements in the curriculum, the question content, the image content is now online based. Or I guess electronic instead of paper-based with a pen and pencil like you and I remember taking it and squinting and couldn't see the pixelated gray figures. So they've done a great job, improving that exam. So and they've made a lot of changes to reflect some of the blueprint for the ABP and exam. So at the AAN conference this April, they announced that they're going to do another review of the performance on the in-service exam in relation to boards. And hopefully that should be coming out in the next year or so. So I'm really curious to see what the new data is, because the exam is now so dramatically different. Because that's really something that I need to know as a medical educator when I'm, communicating with my trainees. Because realistically, I kind of want to know what is the threshold for my graduating class to perform at, for me to say you have nothing to worry about, or to put someone on alert and say, listen, you really need to buckle down and spend a lot more time learning and paying attention and focusing on these aspects. They do give you that kind of detailed breakdown of not only what subjects people struggled in, but also what topics, whether it's like easy, medium, hard, they struggled in, and also like at an institutional level too. So I think that's really great as a medical educator to review all that information, to kind of potentially make some modifications to your curriculum in any individual year. If you know that your school struggled in neuroinfectious diseases, that might be something you want to add 1 or 2 lectures on, incorporated throughout the academic year.
No, that's great. And I do remember anecdotally my my own scores, and I like to think that they're fairly representative of most junior residents back then, which would have been like neuro-oncology, pediatric neurology.
Yeah.
And then a lot of times, especially as a PGY2, like a lot of the pathology, like neuropath questions, those are always one of the things where it's just like ripe for questions.
Yeah.
And I remember, as you said, it's someone who's a little bit away from that now and not working directly with neurology residents as often. There was always a lot of complaining when the right exam time came around, because there's like such a disconnect in terms of what they were asking you versus what you were likely to be seeing on your board exams, that it was felt, to use some extreme language, like a waste of time to an extent, which probably a bit of an over-exaggeration, but we all know how you can be when you're in residency and tired and frustrated. Any
core faculty member in medical education in neurology are going to hear that after the exam, like, oh, they ask these mundane, intricate little questions. But I always kind of explain there's clinical fund of knowledge, like practicing fund of knowledge, and textbook or board exam fund of knowledge. And yes, there's significant overlap, but there's a little bit on each side of those that are not going to be applicable to both. And you just have to be aware of that and really focus your time when you are learning independently on those kind of things that are outside that Venn diagram. I think one of the biggest criticisms you could have about the in-service exam as an adult neurology resident is that they do have a lot of pediatrics and a higher percentage of pediatric neurology on it compared to what you're going to be taking on the adult neurology board exam. And it's because it's created to be taken by both pediatric and adult neurology residents. There were some discussions, again, in April this year, of possibly separating out the pediatric and the adult neurology residency and service examinations, which I actually think would be a great idea, because then you'd be able to have the exam more reflective of what those future trainees are going to take. And with, I think, the team that they have in the AAN, I think they definitely would be able to create a question bank that would be large enough to be able to serve both of those means.
No, that's a great point. I've heard similar discourse as well from some of our child neurology colleagues. And yeah, it is one of these things where we see this continued, I hate to use the word balkanization, like even within neurology, adult neurology. And there's just such a vastness of information that it does become almost challenging to say, like, what should a graduating general neurologist know? And that's I think becoming a harder question to answer at times. I'm curious what your perspective is as someone in kind of more involved in training residents at present.
They say teaching is the mother of all professions, but right now it feels like it's happening inside a pressure cooker. That's why we created Higher Listenings, bringing a dose of joy to the future of learning. We're exploring things like why reading may not be obsolete after all, the remarkable connection between emotion and learning, and the real reason students cheat.
It's not a moral failing. It's the circumstances that they find themselves in.
Join us in Higher Listenings, because those who can make a difference teach.
Yeah. So it is definitely getting harder, I think, to figure out like what esoteric information is really needed. And I think both you and me, Mike, now we've been around long enough, as much as we wouldn't like to admit, to have seen that kind of evolve over time. Because I think historically there was a lot more neuropath evaluated, a lot more of the biochemistry, lysosomal storage diseases, things like that are being incorporated. But now things are just a little bit easier to do. I think the role of a neurologist has evolved over time too. And I think one of the hard things too is just the evolving range of neuropharmacology available. If you think about just like all the MS therapies that have been approved in the last 5 years, it's overwhelming. And how much of all of that does a neurology resident need to know, being that they might not really be practicing that aspect in great detail. And I think that's a big struggle that a lot of question exam companies struggle with, because when you are creating an exam, right, you want to have people in that field that are very knowledgeable in that, right? So you might get one of the figureheads in some of these subspecialties, but the more subspecialized I find someone is in a certain field of medicine, the harder they are at creating, questions or teaching points that are really reflective of what a foundational trainee would need to know. So there's always that constant battle. So that when we have like people contribute to Now You Know Neuro, I actually usually like to have people that are more in the higher tiers of their graduate medical education, or just out of training or in residence or in fellowship, because they kind of have a better idea of what that foundational knowledge is as opposed to like that super subspecialized components.
No, that's a great point. It kind of puts me in mind of some of that YouTube video series where, like a physicist explains black holes at 5 different levels, down to like a kindergartner up to another PhD. And you do get some of that sometimes in like a lot of medical education writing. Like you said, it's exactly what you said. You get these deep, like they're at the cutting, bleeding edge of research, and you get like all this minutia of like these drugs coming down the pipeline, and like we think they get really mechanistic, and maybe the general neurologist out there just needs to know, like, do I need to check liver enzymes periodically on this medication, or what's up?
Yeah. When do I refer to a specialist?
Yes, exactly.
When do I submit it to the epilepsy monitoring unit? Things like that.
Right.
And, yeah. And that ability to communicate at what I argue is like an 8th grade reading level is really also can be valuable in patient care, right? One thing I've also have experienced when I work with newly graduated medical students in residency is that they have this huge fund of knowledge they want to show off, right? Because they've worked very hard to get to where they are. And then when they're communicating things to their patients, sometimes it's at a high level where you would need to have that graduate degree to fully comprehend the whole conversation. But being able to communicate that in a very easy way, or really understandable way, would be something that your patients are really going to appreciate, right? Because then they actually have understanding of their own health.
Yeah, I know I was guilty of this the other day, because I always ask the patients when I'm explaining something, how much do you want to know, right? So
great question.
I was talking about functional neurologic disorders with someone, and they wanted to know more. So I was like, so we talked about the interoceptive network for a few minutes, which to be honest, right, it's one of those things that, again, right, we don't necessarily learn as much in residency. But you and I, we both did epilepsy fellowship, and it's something we see all the time. So I have this book now on my shelf where I kind of go back, right? Like I get through all I've got the clinical foundation. Now I can go back and like dive into some of the neuroscience, right? Instead of being like a pretend neuroscientist, try and get some of the actual foundational information there, and read more about some of these things that I hear these researchers talking about. So I have some foundational understanding, and hopefully I can use that information that I accrue to explain it in a more clear and concise manner, as opposed to for those who are familiar, like the common analogy used is like the software-hardware mismatch, which, not entirely accurate, right? Like most analogies, it breaks down at some point. But But right, the more we know, the more creative we can be in terms of our descriptions, and hopefully communicate things more accurately, kind of meeting the patient or the learner where they are.
Yeah. Also, a good concept on top of that is too is like understanding what their understanding is of that diagnosis to begin with, right?
Right.
Especially again in that realm of conversion disorder or non-epileptic events. There is such a stigmatization of that. They may have been told that they're crazy, that they're doing this on purpose. It's all in their head, like all these kind of huge things that are obviously nothing that any trained epileptologist would ever say in a patient room. It really kind of helps you get preps you for that type of conversation and seeing how much empathy is needed to kind of convey some of these teaching points or these educational points for the patient.
Absolutely. Now, one thing I'm curious to hear your perspective on is, so I was at neurology residency for my first few years out of training, and I moved, and I'm currently at a community teaching hospital. So most of my educational role is dealing with non-neurology residents, so internal medicine, family medicine, emergency medicine, and so kind of these frontline, primary care physicians or physicians to be. Right, well, no, they're physicians. They're soon to be independent.
Yes,
and so getting them acclimated with common neurologic disorders that I try and do my best to identify, like, what are the most important things that they need to know if they're, because there's plenty of neurology deserts throughout the country, let alone throughout the world. So how can we get these primary care physicians to kind of get the essentials down so that they can hopefully manage some of the more common disorders out there? And I'm curious, like, in someone who is in a more structured teaching role, how do you find that integrates into kind of the overall structure of the neurology residency program?
Yeah, I mean, I think every neurology residency program would probably still have trainees rotating on their services that are outside neurology, right? You have psychiatry has to do neurology exposures, internal medicine will come through. If you have neurosurgery, they may be rotating in your vascular neurology in-service services. And I think it's really important that you have some personalization based on the type of training that person has, and also how much time you have with them, right? If you only have like a week with them, how much are they going to get out of that? You're kind of limited, and you're not going to cover all the bases. But whenever I do work with anyone outside of my residency program, I kind of always want to know what their future goals are regarding their career, like what career path they're going into. So then I can kind of modify my educational teaching points based on those components, right? If someone's going to be becoming a neurohospitalist, I might focus more on like the altered mental status evaluation, first time seizure, values of an interpretation of CT scans versus MRIs. If they're more outpatient, then you're going to be focusing more on like headache management. So it could be doing some epilepsy or seizure for syncope. That's a very common outpatient. So trying to get that subspecialization based on their career goals, I think really helps those people leave with the type of fund of knowledge that would be the most valuable for them.
No, I think that's great. But yeah, there's no one size fits all, certainly. And yeah, I try and do that as well. The ebb and flow of the hospital and the clinic sometimes doesn't always lend itself as well as we would like,
of course,
to getting them that direct patient experience. But I think those are all great points. Do you find, like, in terms of your neurology staff or even the neurology residents, I remember as a resident myself, we would sometimes go like to our psychiatry residency colleagues, and we'd do some of their lectures, like a lot of times as part of their in-service exam prep. And we would usually be scheduled kind of on a rotating round for different topics and so forth. Just curious perspective, like resident as teacher versus attending as teacher, any significant opinions or perspectives?
Yeah, I mean, I think that's a common attribute in all residency programs is to have your own trainees, educators within the program, as well as trying to have people outside of your residency involved as well. One of the best ways to learn is to teach. I really do believe that mantra. And it really kind of pushes you to have that fund of knowledge to be able to not only present the information, but probably be able to also address follow-up questions as well.
Mm-hmm.
For what it's worth, the psychiatry has their own in-service exam equivalent called the PRITE. It's administered in the fall every year. So there are opportunities, I think, because there is a significant overlap between the curriculum of the ABPN psychiatry exam and the neurology exam, that there is things that can be addressed in both of those avenues, especially neurocognitive diseases, neurodevelopmental, even some basic neurology like movement disorders and stroke are going to be seen on your psychiatry and service and board exam.
Something I know, again, right in the epilepsy world, I think it's around 80% have some sort of comorbid psychiatric diagnosis as well. So it's, a lot of times neurologic and psychiatric disease travel together. And something I had looked up actually in the past is that if you look at like the number of psychiatry versus neurology training programs, I think there's something, I want to say around 100 or plus more psychiatry training programs out there than there are neurology. And so one of the things that sometimes I wonder about is, what are these kinds of programs doing as far as their neurology exposure? They may have, like private practice neurologists or hospital employed neurologists, but it's not as integrated or structured per se as what we might see in a place that has both a psychiatry and neurology residency training program. And then just to take that to the further extreme, if you look at the number of internal medicine residency or family medicine residency training programs out there versus, right, we're talking a mismatch of like 10 to 20 to 1. Right, so these places are definitely going to have, I again, right, I'm making some assumptions, but I can only imagine they would have a less structured educational experience in the neurosciences as compared to a place that has a residency training program in neurology. I don't know. Is this something that's ever crossed your mind, or, yeah?
Yeah, I mean, for what it's worth, I've always been at a place that had both psychiatry and neurology residency programs. You're right in the fact that there's, for every one neurology resident, there's 3 psychiatry ones. So it's a much larger field of medicine I think for a lot of obvious reasons. We do have our, I think the amount of training the psychiatry residents do in neurology is probably comparable, I think, to what the amount of neurology residents do in psychiatry. So it's not like a very a significant amount of time where you are in that other respective field. So just enough to kind of get a taste. You're right that you'd think that if you're not at a very large, robust academic program where you have both neurology in addition to your psychiatry, the training might suffer. But I mean, that's true you can say that same thing in medical school, right? So a lot of DO programs don't require neurology as a core rotation. So a lot of these people are ending up, looking for electives that might not be as academically, versed. But I think you try to find the best opportunities out of that to optimize the learning experience and then kind of grow from there.
And, as I am a DO graduate, and that is exactly my own experience, right? You kind of would cold call places and be like, hey, could you take a medical student in February this next year? And sometimes they would say yes, sometimes they would say no. And it is one of those things. I think it's something like a third of medical schools don't have a neurology clerkship, right? So there is this lack of exposure for many of our colleagues.
And despite that, over 15% of neurology residents are DO grads. So despite even that additional diversity to overcome, a lot of people are still able to successfully, match into neurology residency.
Yeah. And it's very interesting. When I talk with a lot of people in medical education within neurology, we talk about like this pipeline from medical school to residency for neurology trainees. And if you look at like the match data from last year, I think it was like 95% of programs filled in the match.
It was 99. There was like one spot out of 878 that didn't match.
Right, which is wild, right? So I don't know if that's the issue anymore. I think what we're really suffering from is a lack of neurology residencies. Like we need more programs to make more spots so we can drive that number down. So then we can worry about the pipeline.
Yeah.
But
So,
yeah,
I mean, they've been growing the residency in the same match, file. I was actually reviewing it in preparation for this meeting
yeah.
today. Neurology residency programs are growing about like a 2% rate
Hmm.
per year. So that's the number of spots. So when you and I were in training, we were probably closer to 800. Now we're closer to 900. We might get over 900 in the next year or two with programs continuing to grow and new ones, starting.
Hmm.
Um, and yeah, it's nice to see that it's one of the programs, one of the training subspecialties that are so easily filled. Yeah, it means that we are definitely a training subspecialty that has as many spots, if not enough, for people that are interested in it. And yeah, and it's something that you have to kind of reflect and look at over time because some residency programs are not, residency subspecialties are not seeing that same interest in the field, and other ones are growing exponentially larger over time every year compared to us.
Yeah. Yeah. It's definitely very interesting from that perspective. And it does make you wonder, right? Because like those of us, again, who are kind of in this space, there have been a few papers over the last 5-7 years talking about the projected mismatch of demand versus like practicing physicians. And it's only expected to kind of get worse over the next 10 to 20 years.
For sure, yeah. It looks like if you look at the data, they have that graph of years with on the x-axis and on the y-axis the number of positions, and it's growing at the fastest rate it's probably ever have since they've been keeping track of the data. But they haven't had a match of number of applicants to the number of positions, since the 1970s. So it would be something that I think they'll never catch up with because I think everyone wants to be a doctor. So there will always be an interest, and I think there's also a huge growth of international applicants too on top of all of that. So we're not only accepting people within the U.S. Medical education system, but a large fraction out of international grads too.
Right. I think it's, and I apologize, I'm a little vague on some of those. I think it's around 20 to 30% of practicing neurologists are international medical graduates.
Yeah, so 204 of the 878 matches this year were international IMGs, and then additional 55 people were U.S. IMGs.
Yeah, right. It is one of those things. And something that's very, very interesting to me also is, and again, I don't know how familiar you are with it. So again, but the visa program in the U.S. for some of these graduates, it's because at our program here, we'll have, for instance, a lot of IMGs in our internal medicine program, but the hospital, even though we are fairly remote from a lot of bigger cities, we're like 50, 60 miles away from like Cleveland, Pittsburgh, we're kind of in the middle of our own area. And we have a very underserved population, both in the urban centers as well as rurally, that we don't necessarily fall under the classifications for like an at-need designation for some of these visas. And when I hear this, I'm just like, you've got to be kidding me. Because we don't meet these certain criteria, but like you look around with your eyes and you're like, we definitely need them though.
Mm-hmm.
And it can definitely be a stumbling block for a lot of people to find jobs after training. And I don't know, residents coming through your program in terms of like visa status and things like that down the road, is that something that you kind of have to help them navigate to an extent?
I'll be honest, I don't have that much experience with it. I know it's something that many residency programs take very seriously in the process of screening people to know what type of visas they would require and if their institution is willing to support those types of visas. And, I think the biggest thing that you hit on is the fact that, after you're done with your training, you need to be somewhere, I believe, in an underserved population. And I don't understand not that I don't understand, I just actually don't even know the criteria that need to be met by a hospital system or individual hospital to meet the criteria. But it seems like it's pretty there's not that many in relation to the many of hospitals that are out there.
Yeah.
So it is an extremely stressful situation for IMGs in the U.S. educational system to understand kind of what their next steps are beyond training. And it's a shame that they have to go through that in comparison to U.S. grads, which are really kind of they have a wide open door pretty much, beyond that.
Yeah. No, I don't pretend to be an expert in this either. It's just something I've run up against when I've had folks where we're trying to recruit, right? A very small department here. And right, we're kind of cutting out, 25% of the pool right out of the door. And that obviously is not ideal from a recruitment perspective. So just my own personal frustrations on that one also. Kind of dovetailing off of that aspect, kind of looking at the international neurology education front, do you find that in addition to kind of like US based programs, do you find that you're like now neuro or other kind of educational things that you've done in the past are utilized by international training programs?
Yeah, actually, we have had a few institutions reach out for institutional accounts. One of the ones I would mention is there's a program in Jordan that utilizes it. They have a neurology residency program there, and has been well received. They renewed their account this past year. I think one of the unique things that are going to be happening over the next decade or so is there's this evolution of something called IACGME programs. Have you heard of that before, Mike?
I haven't.
So it's a process actually of like an international ACGME training program set up. So people would be able to be educated internationally and kind of meet the accreditation criteria for ACGME certified programs.
Interesting.
There's not many out there, and I think the last time I checked, I can't even remember if there's any in neurology. But it's a really interesting avenue because there is a lot of limitations in graduates internationally for future employment in America because of that restriction. So yeah, we do have some international programs. We do have a lot of international people attend our virtual sessions. In January and February every year, we host 5 to 6 hours of lectures live on Zoom. We then end up eventually getting to our library that all our users can access. But I'd say I think over a third of people are international people, looking to learn a little bit. And since we have over almost 3,000 followers on Instagram, we have a huge audience that's well above and beyond, what a normal, or not a normal, but probably the full volume of graduate medical education trainees in the U.S. system.
Yeah, right. It's one of those things where you might feel like you're sitting in your home office or your office at work and you're just talking to a screen. But if there's 1,000+ people on the other end of that recording, right? That fills up a pretty darn big auditorium.
Yeah, for sure. Bigger than the ones I went to.
Right, exactly. Kind of going back to the IACGME thing, I think that's really interesting because I think we've all known one of our colleagues or one of our trainees who they come from another country, either like in the the Middle East. Sorry, I'm in the Midwest. Or China or Southeast Asia, what have you, and it's I was a surgeon there, or I was a neurologist there, and they have to come back and repeat the training, and it just
you have to feel bad for them, right?
It seems kind of mind-boggling.
Yeah, and I haven't had the opportunity of training alongside many people with that career path, but you have to really empathize with that experience. And I have interviewed definitely people that have gone through that process themselves, and that kind of shows you their drive and their willingness to pursue this field of training. Some medical educators I interact with have always said that the international medical trainee cohort are usually some of the hardest working trainees they have at their programs because of that reason, because they've had to work so incredibly hard to get to where they are. They've really, unfortunately, have had to sacrifice many things to get to where they are in their career, that they will do whatever they have to, to become the best doctor that they can be.
Right. Yeah. If you think about it, right, you have to learn new language, move across the world away from family and friends, and then work ridiculous hours for, 3+ years, depending on your program of specialty of choice. And yeah, and plunk down usually thousands of dollars to do it.
Mhm.
Yeah, there's a certain amount of grit that it takes there.
For sure.
As far as kind of people who are looking to get into medical education, maybe they're at a smaller institution or they don't have something structured where they are. What kind of recommendations do you have? It sounds like you kind of just bootstrap this thing up, but what kind of suggestions would you have, or where would people start if, let's say, we've got a new neurology attending who's kind of out in the middle of nowhere on their own and wants to get involved in medical education? What should they start doing?
Yeah, that's a great question, and I definitely try to find people that are earlier in their careers to try to mentor them at this point. I will say, I did have someone like that guiding me early on in my training. So that was Ralph Josefowitz. He was the program director of the University of Rochester for many, many years. He actually was the physician that first published the term neurophobia many years ago. He was a huge person involved in the AN community. He ran a mind-brain behavior course for the more junior medical students at his institution. And I did an acting internship at that program when I was in medical school, and he gave a lecture on the career path of a medical educator, which I still have and I still refer to every once in a while. And he broke it down as early career, mid-career, and late career.
Mm-hmm.
And obviously, the early career was kind of things that I found most applicable to me at the time. And some of the things that were discussed in that included finding a good mentor, looking for opportunities, saying yes to everything, becoming a leader in medical education at your own institution. And then as you got into extended phases of your career, you start to get recognition from a national or even an international range. So that's really what I focused on. As a resident, I got an award as a medical student educator of the year, and then as a fellow at Rochester, I got a fellowship educator of the year. I got involved with the AAN community in their Neurology board prep course. Actually, as a fellow, the youngest person on that team at the time. And then, looking for other opportunities to get involved in other institutions. I did my first visit grand rounds earlier this year at Nuvance neurology residency, and have hopefully going to be doing a few more lectures, at other programs regionally close or virtually as well. So, to summarize, look for mentors, look for opportunities, and if you're really going to pursue a graduate medical education career, whether it's like a clerkship director, fellowship director, you really kind of need to start by getting your foot in the door in some way, working in the resident clinic, having trainees rotate with you in clinic, giving lectures, and then hopefully that would transition to more leadership positions that are not things that are considered core or time. So that could be being part of your program evaluation committee, which meets intermittently throughout the year, that reviews the curriculum or the training experience of the trainees, the clinical, the CCC, which evaluates resident performance and giving feedback of what needs to be done if anyone is in risk for remediation or anything along those lines. And then as you get more kind of non-protected time leadership positions, as other opportunities open up, then you would be the one that would be first considered for those roles. So very often you might get your first, foot in the door, and then in a few years you might start getting your first 0.1 or like 4 hours a week of time towards these more educational roles. And then as you become if you have the opportunity to become a program director or an assistant program director, that can be significantly more time.
No, that's great advice. And it is, it's one of those things I'm still working out myself where you say yes to everything. And at some point, you do have to start saying no to things. And it's hard to figure out where that point is in your career.
Yeah, and I think you have to also, at the very beginning, right, you say yes to everything because you have nothing, you're not doing anything else.
Right.
But there is definitely a point where you'll be stretching yourself too thin. And I've had to say no to a couple of opportunities. For example, I was for a little while, I was involved in the interviewing of medical students for the program I'm at. And did a couple of those, but because of the day that they were doing the interviews and having it kind of run in line with our resident interview season, it just wasn't realistic for me to be involved. I wasn't able to really give it my full effort. I wasn't immersed enough to make it an efficient process because I had to kind of relearn like the system, the platform, and the process every time I did an interview here and there. So by the time you can really start saying no. That's kind of when you already have your foot in the door, so to speak, and really trying to be reflective on like how would this optimize my career path, my career goal of becoming a program director, a clerkship director, or even like a shorter step like an assistant program director, things like that.
Mm-hmm. No, that's great points, and yeah, it can be hard to navigate, especially when you move into those new roles, especially when you're first out of training.
Mm-hmm.
But I think you had referenced this earlier. It's kind of like finding that mentor, someone who's kind of doing what you're doing or what you want to do to an extent, and hopefully ask them for advice.
Exactly. I think also the last thing I would say is that I think you also need to be very vocal about what your goal is, right? I think if no one knows that is a career path you're pursuing, they won't consider you, or maybe even offer you opportunities to kind of build your educational profile to be considered when that opportunity becomes available. So telling your the head of your department or the program director that you currently are associated with or something, let me know. I'd love to do whatever I can to be considered for a core faculty position when the next one becomes available. What kind of career path or what steps do you think I would need to complete to get to consideration when that happens?
Yeah, no, those are great things. Yeah, I know I've gotten away from like the pure academic employment setting myself. So these are considerations that I have long ago put to the side, unfortunately. But it is. I know there's a lot of folks out there who are in that setting, and it's always good because everyone's employment situations or work environment can change over time. So it's always good to kind of remember these things because it is its own unique animal in terms of like kind of the academic hierarchy and structure.
Absolutely. Such an independent system is what I've learned, right? So your ACGME model or leadership is totally independent of your clinical care model. So knowing kind of who to communicate for certain aspects of your career are important. And the turnover is pretty high. The last time I heard, I believe a program director's average lifespan is about 5 years. So many of us would be practicing for 30 plus years in their lives. So they may, if they're at the same institution that whole time, there might be 5-6 times that there's turnover in that leadership position, which provides a lot of opportunities for more time and more different roles.
Yeah, no, that's a great point. They don't want things to get stagnant, and it's always good to get fresh blood, fresh perspectives, things like that kind of in there. Although you certainly hear stories about these kind of legendary program directors out there who have, done it for 10, 20 years and things like that. And, did an amazing job the entire time.
Yeah. I mean, those are real people that are really dedicated to that role and are really passionate about their job. So Ralph DeCefowicz was one of them. Deb Bradshaw, University, SUNY Upstate, was there for many years. Zafar Khan, I believe he was there for many years at Emory as well. I think Chris Lee at Vanderbilt now has been there for a good amount of time too. So I mean, there's many more that I'm forgetting. But you're right that the longer someone usually is in that position, that usually means that they are very, very good at their job and really passionate about it.
Yes. Any final thoughts? Any advice to those kind of early career, whether they're med students interested in neurology or residents or fellows? I know we've kind of gone through a lot of that stuff already, but like if you had to summarize your best recommendation for people looking to pursue a career in academics or kind of bootstrapping their own academic projects.
Yeah, I mean, I think regarding projects and research, I think that's something that a lot of trainees don't have a lot of experience with. And they very easily can get guided into a wrong path or a very inefficient path. So whenever I talk with my trainees and they're coming up with study designs or questions, I usually have them answer 3 questions before we get started. One is, do you have a good question? Like, is this something that people are going to care about? Or is this question already been answered? 2, do you have a good study design? So no matter what, if you have a very good question, if your study design is garbage, no one's going to accept it because it's just not a good study. And 3, do you have a realistic timeline? Do you really have the time to see the study through and through? If you're a medical student, you have 3 more months at your training program before you go into residency. You're not going to write an IRB for a study that takes 3 years to collect data on, right? So, if you are able to get those 3 things identified and I'm satisfied with it, you'll get the green light for me to pursue. But, Mike, I'm sure you have, just like I have been involved in projects that just went nowhere. And I mean, I probably have wasted dozens and dozens, maybe even hundreds of hours of research time into projects that maybe got an abstract at a conference that could have easily been comparable to a case report I wrote, in 30 minutes. That is so frustrating, and as a medical student or an early resident, you don't have that insight into what those things are. What's a good study design? What's a good question? What's a realistic timeline? So focusing on those aspects and thinking about how this actually will help your career path move forward is really something really important. The Now You Know Neuro Instagram page is something that I follow. I create. I'm the one that probably reviews it almost daily. I'm the one that makes all the memes for anyone that was curious about that. We also, have info at nowyouknowneuro.com. If you want to email us about, setting up institutional accounts, you can find that on our website at nowyouknowneuro.com. For anyone who is interested in psychiatry, we actually launched a sister product called Now You Know Psych for psychiatry residents. They also have 1,000 flashcards, chapters, question bank, pretty much everything comparable to Now You Know Neuro for psychiatry residents, and we're hoping to grow that over the next year or 2. And additionally, we'll be launching actually an application very soon called Now You Know Med, which is going to be housing our question banks and our flashcard decks for both neurology and psychiatry residency resources. So that'll be a mobile app available, in the next couple of weeks, if not a month or 2.
Awesome.
That I think a lot of our subscribers are going to be very excited about, because that's probably one of the only things that kind of are different from our resources compared to some of the better known ones like Board Vitals and things like that.
Awesome. No, that's great. So again, right. Thank you everyone for listening. You can of course find me on Twitter/X at Dr. Kentris, and then you can always check out theneurotransmitters.com for more information about all of our work. Dr. Hanrahan, thank you so much again. I appreciate the talk, and I always enjoy getting a fresh perspective on medical education. It's always refreshing to me to talk to someone who's kind of at least, if not more, into this stuff than I am. So I appreciate you taking the time to talk with us today.
Pleasure of mine, Michael, and great to see kind of this neurotransmitter community grow and develop over time. And I'm sure you've been strategically and significantly involved in helping that foster and grow. So I wish you all the best with future growth and development, and love to be more involved as things move on.
Thank you. Appreciate it.